Hey everyone, welcome to EMRAP Grand Rounds. I am Britt Guest, and I am joined not by Scott Kobner, but instead Jan Shoenberger.
Yay!
Woohoo! Thanks for joining me. So Jan, we've got a super exciting show lined up. Who are our faculty joining us?
So our faculty today are the amazing Amal Mattu is going to join us virtually.
Whoop,
Everybody
whoop.
knows Amal. Of course, it's going to be an EKG segment, just to give it away.
Spoiler alert.
We are also joined in studio by none other than the Dr. Stuart Swadron over here. Fantastic. And we will also be joined virtually by Dr. Scott Kobner.
Awesome. All right, so headlines, bottom lines, don't have a bunch tonight except for...
We were at ASEP in Philadelphia.
We did ASEP.
We did ASEP. We had a booth. We did a half-day event. It was really fun. We got to meet a lot of people live, do some procedures. It was actually really fun time.
It was really fun. I think it was really fun to have like an interactive booth and have everybody come in, see like kind of the behind the scenes of EMRAP, and we did a lot of crikes and a lot of chest tubes.
A lot of people died those days. Yeah.
No, they were all saved.
Yes, that's
they were
true.
all rescued. All right, so let's just jump into the show, Jan. What do we have next?
Why don't we? Let's do some clinical images, Britt.
Love it. Let's do it.
It was all a dream. It was all a dream.
All right, everybody, let's jump into clinical images. So my first image of the evening for you guys is this. Let me give you a little bit of clinical context. You've got a patient coming in, 35-year-old female. She's saying she has this horrible headache. Can't really give you a lot of information about it. She just doesn't have a history of migraines. Something sounds a little concerning. You scan her head. It's negative. You decide to do an LP, and this is what you see.
I'm guessing the headache was quite a while ago.
The
What's our
headache
timing?
onset, let's say, it was about 15 to 20 hours ago.
Okay. All right. So a bit of a delayed presentation.
Yes.
So we see obviously some discoloration.
It's not urine, Jan. That's
Are
all.
you sure? Are you sure?
You didn't trick us by putting a little urine in there. No.
Yeah.
It's yellow.
Yeah. Yeah. So, this is obviously a CSF tube, I think, and we've tapped her. And this looks like xanthochromia to me. I mean, I think that's what we're seeing here. Obviously, they have it held up against the white background so that you can tell the difference. That's one thing they do is hold it up to paper. Now, this is mostly done by chromatography these days. It's not really done by the site test, except in places that don't have a chromatograph.
Yeah.
Yeah.
Well, actually, the last time I checked, a lot of big name hospitals in our area actually were just using the
Still doing it this way.
visual inspection technique. And we know that's not as sensitive as the photospectrometry or spectrophotometry.
Yes.
I always get those two,
Yeah.
I always say them backwards. Yeah, but anyway, that's definitely more sensitive. This is something that, so we're thinking that she has a subarachnoid hemorrhage because we know that xanthochromia takes, it's a breakdown products of blood, right? So as the blood breaks down, it takes a while, and it's not till about 12 hours after a subarachnoid event until you reliably get xanthochromia in most of the patients, over 90% of the patients. But I think that the take-home message with xanthochromia is that it's not the big deal that it used to be. Like when I was first learning about that, it was like, this is the gold standard. I remember even in Europe, they used to wait 12 hours before they would tap a patient because they wanted to make sure that the xanthochromia would reliably be present. And I'm like, how could you do that? They could bleed again in those intervening hours, so we don't do that. And then together with the fact that, it's not necessarily accurate in a lot of hospitals, and the fact that you're gonna have blood cells there. I mean, this patient would have blood cells. And so, as opposed to a technique for really distinguishing a traumatic tap from the real deal, I think in this day and age, you're much more likely to do a tap in another place and get a cleaner tap, or to get an angio.
Right.
You're much more likely not to rely on xanthochromia. It's not the big gold standard that we used to think of it as. I think that's the take home.
Yeah, and I think, I'm just telling you 20 hours, but likely this would be something a little bit later, right? I think that we're always going to get that head CT, and the head CT is really, really good for picking up blood. This, I think important to realize that that breakdown of the hemoglobin and the bilirubin that makes this color can actually be there up to 14 days. So my God, that would be a pretty late diagnosis of this subarachnoid hemorrhage. But yes, that discoloration will last a pretty long time.
And CT is good for blood, but really in terms of following the evidence, it's really up to 6 hours is what supports in terms of a time cutoff.
Right.
So, yeah.
Okay, I should mention that these are color themed images tonight, okay? So this is your first color, this light yellow. The next one is, and we're right, this is xanthochromia, of course. Our next image, this is somebody's urine bag. This is an 80-year-old female. She's coming in kind of just, I don't know, not really feeling too much, maybe a little nausea, maybe a little under the weather, and her home health care nurse notices that the urine is now purple, and they're totally freaked out by this. What are we thinking about here?
I can understand why.
Well,
It's super scary looking.
It looks like she's like eating those purple Crayola,
Yeah.
I mean, that's like really weird. But I just know that in general, whenever we see weird colored body fluids, we panic, and then most of the time it's not something that's like the biggest deal in the world. Like usually it's like, so I if I had to guess, I would say that this is just a UTI or something, that's what I would guess.
Yeah, I think this is caused by breakdown by certain bacteria. They make it this weird color, and but it's pretty fascinating. It could also, when I see weird colored fluids, think about tox, stuff like that.
Sure.
But I think old lady, this is your UTI. This is probably the byproduct of some kind of bacteria. I can't remember exactly which one, but I think multiple bacteria can do it.
So this is purple urine bag syndrome, which
Of
pretty much
course it is.
describes exactly what you're seeing, but that's exactly right. Typical risk factors will be older, a lot of comorbidities. Females tend to get this more often for whatever reason, a lot of recurrent UTIs, and an indwelling Foley that probably just doesn't have the best hygiene in the world. Common bugs are really the common bugs that we think about with UTIs, things like E. coli, Pseudomonas, Klebsiella, those types of things. And for whatever reason, there's some enzymes in there that break down bacteria and it turns purple, which is pretty cool. So purple urine bag syndrome. All right, my next color for you comes in this form. So this is a 48-year-old male. He's coming in with some pretty bad upper abdominal pain. You order some labs, and the nurse gets those labs and comes to you and says, "Doctor, like, this is their blood. It looks so crazy. What are you thinking?"
Yes, this is lipemic. It looks kind of milky, fatty. It is pretty bizarre as it comes out. So I'm thinking about it being fatty triglycerides.
Yeah, it definitely looks like fatty triglycerides, and it's not actually that unusual. I mean, every once in a while, a nurse will come up to you and say, "Oh, look what I just drew on this patient," and people kind of freak out. But obviously, it's a risk factor for MI, and there are people with congenital hypertriglyceridemia syndromes and stuff that we have to know about, and they have risk factors. But a lot of people just have this and not know it. Like, I mean, this is something that I've seen from fairly young people, and it's a big deal when you discover that. Has implications for them. But a lot of times it means nothing. Acutely, it's just like in a blood draw.
Yeah, I'm gonna guess it's pancreatitis.
Yeah,
because there was abdominal pain. This patient has.
Yes, getting
This
back to
patient
our
has
case,
abdominal
in the
pain,
setting
yeah.
when you see this with your patient that has abdominal pain, this is in fact causing pancreatitis. It's the third most common cause of pancreatitis after gallstones and alcohol actually is high triglycerides. So it's kind of become my practice now to check a triglyceride level, which isn't a lab I order all that often, but if I have a patient with a story for pancreatitis, but nothing else that fits that picture, like they just don't drink alcohol, like don't see any gallstones on my ultrasound, then I will go ahead and order the triglycerides. And I want to kind of give a shout out to Pharma Core P here because the treatment is insulin. You start an insulin drip. And I just had this patient a couple weeks ago, and I think I had to literally explain to almost everyone working in the hospital why I was starting an insulin drip on somebody with a perfectly normal glucose that did not have DKA or even diabetes. And so you might have to tell people why they think you're acting crazy, but really you do start them on an insulin drip. And for most hospital protocols, that buys them admission to the ICU. So it really changes their disposition.
I was
Yeah.
just so happy when I saw that you looked that up in Corpendium, and it was right there, and that's beautiful. And then you could just show that to people, say, look, here it is in Corpendium.
I did,
Yeah.
because I really did I even got the pharmacists upstairs and in the ER both calling me like, Dr. Guest, what are you doing? I swear there was a reason to my madness. So yes, hypertriglyceridemia is the answer there. I want to bring up one more image. This is going to be our mystery image of the evening. Now, this is a patient who comes in with some eye irritation, feels like, it's been windy and he got some dust particle or something in his eye and is just a little irritated. You notice that, the eye's irritated and there's some tearing from that eye, but the tears are kind of this orange color. So the question is, what is the most likely medication that this patient is taking? First one to answer it correctly in the chat wins a prize, pair of AirPods. Get in there. What do you think that medication is? Don't say anything, guys. Lips sealed. All right. Moving on to our next segment. This is going to be Procedure of the Month virtually with Dr. Scott Kobner.
Hey everybody, and welcome to this evening's Procedure of the Month. We're going to do things a little bit differently this month, and we're going to review 2 videos of bleeding AV fistula repairs. And we're doing it this way because it's a little bit hard to demonstrate a gushing arterial venous fistula in the studio and kind of the chaos that's surrounded in the care of those patients. It's a total bloodbath, and it's an emergency that you need to know how to handle in order to save somebody's life. Dialysis fistulas are super, super common, and it turns out when you have a graft that is just chock full of blood that is being pounded by the arterial and venous blood supply, sticking a needle in it 3 times a week can cause some problems. And so we'll see a spectrum of illness here, all the way from a small little pinpoint needle from dialysis access that won't stop oozing, all the way to someone tripping and falling and lacerating their fistula and exsanguinating in front of you. And so these 2 videos give examples of 2 different techniques you can employ to really manage these life-threatening emergencies. Let's jump into the first one. It's from Al Sacchetti right now, and we'll start it off here. So we're off to a great start in this video. You can see clearly it's the patient's upper extremity. They have a bleeding fistula, and right here I'm going to pause. You see what the person with the white gloves doing with their right hand. They're just taking one finger, right? One single finger, and they're putting that right on the bleeding site. They're doing that to maximal occlusion of the bleed, direct pressure. This is great technique here. We've got some gauze nearby. Really important to help mop things up. But more importantly, potentially than the gauze, is the amount of PPE these folks are wearing. So if you have a heads up EMS run, whatever, that you're going to get one of these patients coming to your department, face shield, gown, gloves, you could see that this is a huge arterial spray mess. You just want to make sure that you're protected, everyone on your staff is protected. Then again, sometimes these people just run in and you don't really have a lot of time. Try to swap out people, get them PPE'd as needed. So now we'll see this person with the blue gloves coming in, providing some gauze. Now, I like to use gauze that's been impregnated with TXA, even a little bit of lidocaine with epinephrine, anything that you can use to help tip the coagulation cascade into your favor while you're applying that direct pressure. And the first step here is just get control of the life-threatening bleed. Now you can see they're employing another technique. The person with the white gloves is now moved to occlude proximal and distal to the bleeding site. And this has allowed the person with the blue gloves to actually take that gauze off and visualize what's actually bleeding. This is such an important point, and it's the mainstay of management for these patients. Because a fistula has a dual blood supply, it's got the venous blood supply coming more distally and the arterial supply coming more proximally, you need to occlude both ends of that fistula to prevent back pressure from continuing to bleed. We normally think massive hemorrhage, proximal tourniquet placement, proximal pressure in order to stop blood flow. Here, you're actually just going to repressurize the venous circuit and the bleed's going to continue. So using those fingers proximal and distal to the site of bleeding, applying direct pressure is a great, quick, easy way to get a better idea of what's actually bleeding on the fistula. Here you can see people injecting a little bit of lidocaine with epinephrine. You could do that to try to help stop the bleed, but really it's to numb the patient up for when you have the suture closed. Now, this is a great point. You see here on the sutures that are being presented, they are using a tapered needle tip. That's the circle with the dot in it on the suture packaging here. This is a really important needle to use because it spreads the tissue out of the way rather than cuts through it when throwing a suture. 99% of the sutures in your department are going to be cutting needles because it's just more useful for us when we're repairing lacerations. This tapered tip, if you can find it, is much gentler should you have to go through the fistula itself. Can cause less damage, can cause less bleeding. If you don't have it, don't worry about it. You're saving this person's life. Use whatever's available. 4-0 sizes here is great. This is not the time to get fancy with a 5-0, 6-0 suture. Throw something pretty big in there that you can tie pretty quickly because you're going to be tying it in some bloody and wet conditions. You want to make sure you have a good grasp of what's going on. So let's see the technique that they employ here. Great. So rather than applying a tourniquet, they're just still keeping proximal and distal pressure digitally. And you'll see it looks like they are attempting to tie a figure of 8 suture in this video. And, some textbooks will say, hey, you're going to suture through the fistula itself. Others will say try to avoid it. The idea is you want to get that suture around the part of the fistula that's bleeding and use the knot to pull the part of the fistula up and abut it against the skin surface, abut it with a knot to apply direct pressure with it. You'll see there's a little bit of bleeding that's going on around the site of the suture, some spurts of blood there where you're making those holes. Even with a taper tip needle, don't worry about it. That's minor. You'll be able to fix that later on. This is the time to be really good with your knot. You need the tightest possible knot you can throw in order to make sure this bleeding stops. And clean up the site, and it looks good. That should be your end result. Perfect for stopping the bleed. All right, let's move on to the second video here. So this second video is from Jess Mason, and it is more focused on just doing the procedure of tamponing the bleeding. The difference in this video, as you'll see, is you've got the patient with a tourniquet directly applied. This patient's already come in with like a pressure dressing, sometimes from EMS. That's a very common thing that you'll happen to see. And so they've applied a combat action tourniquet up on the arm proximally. They're going to use that to tamponade the first part of the fistula. And now you can see that they've got a blood pressure cuff distal to the graft, and they're going to hyperinflate that and maintain that blood pressure so that they can use it as a makeshift tourniquet rather than putting on 2 combat action tourniquets. I would prefer doing 2 of those tourniquets just because it's easier, but if you don't have 2, that totally works. And we see a lot of the same technique being employed here, doing a little bit of lidocaine with epinephrine, some direct pressure. They visualized the problem in the fistula itself, and it looks like they're going to go ahead and throw a figure of 8 suture. Now, I will say sometimes these fistulas tend to ulcerate, and you get a little bit of a hole instead of a small laceration or a puncture over the fistula itself, and a figure of 8 might not cut it. So some textbooks would recommend doing a purse string, which is essentially you're going to suture in a hole around the hole and tie it tight, kind of like a coin purse or a coin bag. That could be great too. I've used that to good effect for an ulcer that I had to repair one time in this situation. But honestly, if you have to throw in multiple figure of 8s, that's fine. Just get the job done. Do what's comfortable and that you know how to do in this situation, because it's not going to be like the cleanest suturing you've ever done because it's going to be very bloody. Most important thing is tying a really firm knot and making sure for at least an hour or 2 afterwards that the bleeding has stopped. One thing these videos don't go into great detail covering is the disposition of these patients. Jess in her video mentions that you're going to get vascular surgery involved, and that's essential. These patients who have a massive fistula bleed need to be seen by a vascular surgeon or interventional radiology, depending where you work and who manages fistulas at your institution. The main complications here are that because this bleeding, have clotted the actual fistula, so they're going to need a fistulogram to see if it's still patent or if there's thrombosis in place. Or it will rebleed, and maybe, this ulceration is going to pop open, which can be life-threatening, or they won't have an access site for their dialysis. So all those things need to be taken into consideration, and generally that's like an overnight admission at most places just to make sure that the fistula is okay, vascular surgery can come see them, and if they need an alternate dialysis access point, that can easily be established in observation or as an inpatient for 24 hours. So that's how you manage a bleeding AV fistula. Not all of these bleeds are crazy life-threatening ones. Some of them are small little oozes that just require some direct pressure. But certainly if you're going to escalate down the, oh my God, this is horrible pathway, remember 2 tourniquets, proximal, distal, direct pressure, a tapered non-cutting needle for a figure of 8 or a purse string suture, and get your vascular surgeon on the phone to help out your patient. That's the procedure of the month.
Oh, sorry.
Hi, everyone. So we're going to do something really cool right now. I have Jan and Britt here. And Amal has sent us 5 ECGs that were dilemmas back at University of Maryland. And so we're going to do 5 cases. And we encourage all the audience to weigh in. As we go through, we'll have a chance to weigh in. Would you call a code STEMI on this patient or not? And so we're going to go through these 5 cases. And Amal's actually going to describe them to us, which is really cool. So without further ado, let's do the first case.
All right, folks, case number 1 was an older guy who had presented to a very rural hospital. And when he presented to that hospital, he had relatively good vital signs, and he was complaining of some chest pain and shortness of breath. So take a look at this 12 lead. What do you think?
All righty. So I'm just going to make it a little bigger so you can see it. And what do you think?
Well, it's not great. It's definitely wide, which makes me go down like, is this potentially VTAC? But I think it's a little on the slow side for VTAC, but it's still on my differential. I'm definitely worried about it being so wide.
Yeah, this makes me think about, when you see this kind of wide complex, and he's got chest pain. So obviously, any EKG you look at, ECG, you have to think about the clinical picture. So this is a bad clinical picture, but could it be hyperkalemia? Could it be, some kind of drug-induced thing? But you have to think STEMI because of the chest pain. Like, clinically it correlates. And I don't like, I look at like lead 3, lead 2, lead 3. Ugh, like just, is that ST elevation there? You see that kind of peak and then it's coming down.
And even here, like in V4, Jan,
yeah.
Like I even looked at that and thought, that has looked like some really big STEMIs that I've seen in the past.
Yes.
Yeah. So you know what? I think this is like, I think this is the most important differential in emergency medicine almost. I mean, this EKG is so important because it's the one that causes, I think, the most M&Ms and the most consternation. And you guys hit all the important differential diagnosis. It could be VTAC. It could be a STEMI, like you said. It could be hyper-K. And it could be, a sodium channel blockade overdose. I mean, it's all within the realm of possibility. And so what I was going to say was that, what can you do if you're not sure? There's stuff you can do, right? So you can give calcium, right, and see what happens. And you can give bicarb.
Right.
And in a case like this, that might be almost a free shot, right? And so,
and you can repeat an EKG.
And repeat an EKG, right, for sure.
And I mean, I'm looking for like the fistula or the dialysis, but if he doesn't have that,
right.
and he's like older with medical problems, looks diaphoretic, I think, like Jan said, the clinical picture and what the patient looks like,
right.
and I'm getting the sense that like his vital signs are okay, but he doesn't look great, I'd be worried about a STEMI.
So that's great. And so as you're, another point that I had about that, and I agree with you, it's like, he's not likely to be an overdose, right? But in terms of the 2 diagnoses that seem to be coming to the fore the most, VTAC and the STEMI, I want to remind everyone that those can happen together.
Right.
And we always talk about STEMI criteria. It's got to be, greater than 1 millimeter. We all know the standard criteria. But don't forget, the other criteria that are also included are hemodynamic instability, like a person's pressure keeps going down, or arrhythmias, dysrhythmias. Right. And so you could argue that taking this person to the cath is good for both of those options. That, if it's VTAC, you still want to try to treat the VTAC, but also be taking them to the cath lab, right? Because of what you said, Jen. So
yeah.
let's see what the outcome was.
All right, so just a little follow-up on this case. Unfortunately, as I mentioned in the very beginning, this was a very rural hospital, and once the diagnosis of massive STEMI was recognized, the physicians initiated their transport protocol, but because it was such a rural hospital, it was probably going to be about an hour or 2 before they could get the transport services to this center and get this patient over to a cath facility. And while waiting for the transport to occur, the patient started to decompensate, went into cardiogenic shock, and unfortunately, this patient ended up dying before he could be transported to a cath facility.
Right. And the question that came up when we were initially looking at this was, well, if it was that long of a transport time and you thought it was a STEMI, the next question is, are we going to give fibrinolytics, thrombolytics, and so that would be something you have to start thinking
Right.
about pretty early in a case like that. What's the downside if you think that's a diagnosis? And
I'd probably assume that they did as they're
Yeah.
waiting for transport, but I don't know. But I want to go back to the poll because we did have a lot of people on the poll decide STEMI, no STEMI. And actually, so it was an acute STEMI and 57% of the audience, or 57% of the audience said no STEMI. So, I mean, still that, like what we were saying, there's a lot of things on the differential there. It's not super straightforward, but in this case, it was a STEMI.
yeah, and thank you, Tom, actually made this last slide for us because I asked for it, because I wanted to make sure that one more time that we remind everyone of what I'm calling almost the most important differential in emergency cardiology. You see this really ugly looking wide complexes. You're not sure which one of these it is. Think of all of them. Think of all of them together. And what if it's this? What if it's that? And as long as you have that whole differential out in front of you, you're going to be okay. It's a matter of thinking about it, right?
So he died. That's a depressing way to start.
Well, Jan, we
Next
learned something.
case.
We learned
Next
something.
case.
Yeah.
We learned something.
Can only go up from here.
All right. Okay. All right. We're 0 for 5 mortality-wise.
Yeah, we're not doing
All right. So case number 2, Amal, hit us.
All right, here's case number 2. This is a 40-ish-year-old guy who had presented to the emergency department complaining of relatively abrupt onset of chest pain and shortness of breath over the past hour.
Okay, let me make it a little bit bigger for
Okay.
you, just so everyone can see it. So 40-year-old, 1 hour of chest pain and dyspnea. What do you think? What do you see?
I mean, right off the bat, I think your eyes are drawn to V1 and V2 because there's ST elevation there, and you see that. And so, but then I go back to Jan's point of like a 40-year-old. We don't have a lot of history, so maybe he has a cardiac history, but 40-year-old and sudden onset of chest pain and shortness of breath. I'm not sure if that really fits my picture, but I'm drawn to V1 and V2. I'm concerned.
I'm definitely concerned. He's going quite fast. This is narrow and fast. So when I see ST segment changes with that kind of a rate, I think, is it rate related? Is this, what is the rate coming from? Because, usually with a STEMI, you're not running at 169.
Right,
so
that's really
I might
fast.
grab an ultrasound, throw it on. This might be a case where I'm looking for more data points. I'm not quite settled on just hanging my hat on those ST changes. But to think, why is it so fast? What else is going on here?
So what are you going to do?
I'm going to
Are
use
you
an
going to call it Code STEMI?
I think I like you. I want a little bit more information. I'm concerned that this could be ACS, but I think there's still more things on the differential that I would want to take a look at.
Let me point out a couple of things to you and I think, let me go to the next slide because I think I have it here. Their ST segment elevation, this patient, one thing in common to all those leads is that they're all looking at the right side of the heart. So the most prominent ST segment elevation here is in the right-sided leads. And you'll also notice here that there's ST segment depression in several leads, right? One has it, AVL to a little extent, lead 2 has it. And so one of the things that I've taught over the years is that if you've got an ECG that has both ST segment elevation and ST depression on it, both, you've got to be careful that you're not dealing with the STEMI. And so that is my first impression as well. I see elevations and I see depressions. But if you just stick with me for a second, the right-sided leads are the ones that really show the most significant ST segment elevation here. It's not the usual pattern, right? It's not the usual distribution. And these leads here, what am I showing this for? Because there's an acute, well, I don't know if it's acute, but there's an axis shift here. You've got a negative, almost negative voltage in lead 1, and it's upright in V2, in lead 2. And one of the things that Amal teaches us a lot is that, be very suspicious that you're dealing with a STEMI if you see an acute right axis change. And you add that to the information that Jan was pointing to about the age of the patient, and geez, it seems a little weird.
Right.
The question here is this really a pulmonary embolus? Because you have that right bundle, or sorry, you don't have the right bundle. If you had that on top of it, even more suggestive, but you have that axis shift and you have the right-sided lead showing the STEMI. So to be honest with you, it still makes me nervous. Like I look at this and I still think I think I would try to make it so that we could get a CTPA like right on the way to the cath lab. Like I'd call them both. Like I'd go down both pathways.
Or take that ultrasound probe and look for signs of heart strain.
Right, I forgot
look
about that.
Quickly if there's a DVT and if you can compress the veins, and maybe a little bit more history on this patient, because young, if he doesn't have cardiac risk factors with sudden onset symptoms, and like you're saying, now noticing the right axis, you do have to consider that this could definitely be a PE. And I think this is somebody I want a little bit more information and a repeat EKG before I would go activating a STEMI.
And we deliberately focus on the ECGs for this exercise, and we don't give that extra bit of history. And obviously history is very important, right? Yeah. So let's see what happened.
All right, just a little follow-up on this case. This gentleman had presented to the emergency department, and what I didn't tell you at the very beginning was that he had a history of paraplegia, and that helped a little bit in terms of coming up with the diagnosis. He ended up having a massive pulmonary embolism. Fortunately, he was treated successfully, and the treating physicians nailed the diagnosis despite the fact that the computer is trying to fool you by calling this a STEMI. They nail the diagnosis, not only the history of knowing that he has a history of paraplegia, but also that rightward axis and ST elevation in the leads that are primarily looking at the right side of the heart. Piece of cake diagnosis, just as the crew talked to you about.
I don't think it wasn't a piece of cake for us.
I think Amal gives us more credit than we deserve.
And the audience too, right? The audience is saying 74% of the audience is calling a code STEMI here. And I
don't think that's wrong.
I don't think it's wrong either.
I mean, there is ST elevation.
Yeah, and they're going to get anticoagulated, so we're going down the right road.
And don't get too smart, right? Yes. Because, what's a piece of cake for Amal is not necessarily a piece of cake for us. But remember his teaching point, because he's seeing this over and over again in missed STEMIs, which is if it's primarily the right-sided leads you're seeing the ST segment elevation in, then check to see if there's an acute, look at the axis, and then at least entertain the thought. You know how this is. As long as you're thinking about the differential, you'll do the safe thing, right?
Totally.
So that's the deal. So that was a massive PE.
That's a good one.
Tough case.
That's a really hard one.
Are we having fun yet?
The paraplegia would have helped.
I know. The paraplegia would have helped.
With a huge right swollen leg.
But
wasn't given up front.
by forcing ourselves to focus on the the ECG stuff, and I actually have another example here. This is a pre-hospital one where you can say the same phenomena. You see that there's primarily ST segment elevation. I think with this one I did it on the, I did in the right-sided, the leads looking most at the right side of the heart, and accompanied by that axis change, which you can see here, where we've got all that negative voltage happening in lead 1 all of a sudden. Okay, so there you have it. Yeah, so think about PE when you have an axis shift. All right. Well, case 3. Ready?
I'm ready.
All right.
Let's do it.
Let's hear it.
All right, case number 3, pretty straightforward history. This was a 40 or 50-year-old guy who had presented to the emergency department with acute chest pain and shortness of breath. Go at it.
Okay, let me make it big for you. Okay, remember, I like that 40-ish-year-old male.
Jan, right. I don't know a lot, but I really think that's a STEMI. I mean, that looks like a classic inferior STEMI.
Yeah.
Am I wrong?
You're not wrong.
Can you give me this? Can you give me this one?
This one, maybe I could say is close to a piece of cake.
This one's got to be a STEMI, right? What do you think, Jen?
Yeah, no, I agree. I see those inferior leads, and whoo, look at lead 2. That's a juicy one, and
the reciprocal changes in AVL.
Now,
yes.
Okay, now Jen, can I be devil's advocate and say, but it's concave upwards, it's smiley face. Doesn't that mean it's benign? What do you say to that?
I hear you, and that can be something that's reassuring, but in this particular case, as big as those are in the morphology of them,
the coronary arteries are not smiling.
And don't forget, we have reciprocals, right?
Yes.
One in AVL, like the other one with the PE, it wasn't a clear reciprocal relationship. This is a clear reciprocal relation. 2, 3 in AVF are reciprocal to 1 in AVL, which both have those ugly depressions, right?
Yes.
So, we've got it here. We've got a STEMI wrapped up. I think that we've got it wrapped up. Sometimes, I don't know if there's another image of this. Well, actually, before I get let's go ahead and see what happened, and then I'll go back. I think there's one more image of this.
Well, this patient did, in fact, turn out to have a 100% right coronary artery blockage. Patients that have left ventricular hypertrophy are so difficult sometimes to diagnose with, is it STEMI or is it LVH with those pesky repolarization changes? Well, this one sure as heck did turn out to be an acute STEMI.
So
Woohoo!
our audience
We got it.
nailed that one. Our audience
Yes.
got 94% of the audience would call a code STEMI on that. Now, Amal mentioned the left ventricular hypertrophy, and that's not something that we mentioned, but it's a really fair point, which is that there's more missed MIs, false positives, and false negatives.
LVH is hard.
For LVH, right? And so it's always high on the radar as something that can screw us up. The thing is that you get ST depression and ST elevation in LVH, but in a specific pattern, right? So here we have the ST segment elevation in 2-3 and AVF. In LVH, you expect to get a little bit of that maybe in V1 and V2. And then this appearance here, let me just highlight this appearance of the strain pattern, right? Yeah, that looks like the LVH strain pattern, but it's in the wrong place, right? It's supposed to be in V5 and V6 mostly. And so this is just not, you would never say this is LVH, even though there is LVH criteria here, no doubt. There's an MI on top of it.
So, Stuart, can you just for a second, because we're getting some questions for the audience, review those reciprocal changes?
Yes, absolutely. And so okay, so go forward here. So these leads, 2-3 and AVF, the inferior leads, are directly reciprocal to 1 and AVL, okay, right there. This is a very symmetrical reciprocity, if you will, right? It's the most exact mirror image that we have in the ECG, the 1 and AVL, 2-3 and AVF combo. And so that's really what seals us up.
So they're doing kind of the opposite, where you're seeing ST elevation from the right coronary artery infarct. You're seeing depression in 1 and AVL.
Yeah,
Those are the reciprocal changes.
Yeah, you're looking in the mirror image, if you will.
Perfect.
Okay, so that was that. And I
Well-
think we got that, that's right, and we got that. So that was a 96, or what was it, 94% success, called the code STEMI. That was great.
Nicely done.
And now we have case 4.
Case number 4 is an elderly woman who presented to the emergency department complaining of some of the symptoms that we would typically consider atypical in older patients. She had shortness of breath, nausea, vomiting, and malaise. So, of course, we're going to get a 12-lead ECG, and here it is.
What are you thinking, Jan?
The old malaise.
The old
She's got the
malaise.
I got malaise.
I got malaise.
Nothing, or she's about to die. One of the two.
Okay, I'll tell you what I don't like.
Well, look, it says a cute STEMI on the top, okay? Does that help? They all say that.
Yeah, they all say that, exactly. What I don't like is I don't like the way the ST segments look. I'm looking at 2, 3, V4.
Let me see if I have one of those. I have one. Yeah, there's V2 for you.
Okay, so we're talking about concavity or concaveness. This is more of a convex, which is to me like a frowny face, and that's not good.
tombstone.
It just, it looks ugly, and I don't like the way it's all mushed up next to the QRS.
But speaking of it being mushed up, it's almost hard to see what the ST
Yeah.
segment
Yeah, I was going
Where
to say,
is
if you
it?
see
is.
ST segment here,
Where is it?
show me
go-
the ST segment before you show me elevation.
Go back to you look at the EKG, and one thing I think EKG, I usually don't pay too much attention to the read on the top, but one thing I think it's really good at is the rate and the intervals. However, this is calling the interval the QTC 411, and man, that looks like a really short QT segment to me. One of the things I think about looking at it is you're like, well, it kind of looks elevated, but it kind of looks elevated everywhere. So could this be pericarditis? Even though this doesn't sound like a classic pericarditis picture, we all know that 80-year-old females don't present classically with much.
Yeah.
Nothing's classic.
I mean, when I first looked, let me just go back to the one that has the waveform on it where you can see it. My first thought was pericarditis when I saw that's what I kind of thought. But then, that's the initial impression. There's no PR segment depression here. And that's a big one for acute pericarditis that I'd like to see there. And like you say, it's not necessarily the demographic. Where's the ST segment? I think I know what you're getting at, Britt, which is that there's something fairly common in older females,
Well,
especially, that can cause this type of morphologic change.
Yeah, I think I wouldn't call this a STEMI. I'd want some more data points, including some labs with some electrolyte values, because
Okay.
I think calcium is something you really have to think about here.
Right, because calcium, hypercalcemia obliterates that segment, right? It narrows it right down to QT. So Yeah, so what would you do? Would you call the code STEMI?
No.
I'm not going to do it.
Someone asked me, someone I think from the audience asked about the calcium. What's the calcium level? Should we tell them?
Oh, I think.
Or should we let
does
Amal tell
Amal
them?
know the answer?
All right, Amal,
All right,
what was
folks, a
it?
little follow-up on this case. This patient did, in fact, turn out to have fairly severe hypercalcemia with a calcium level of about 17 milligrams per deciliter. And as the patient got treated, that T wave slowly moved away from the QRS complex and the ST segment reappeared. It was really cool to watch that happening as we treated the patient.
That's so cool. And that's so cool. I guess she must have been really dehydrated.
Yeah.
Yes.
And they must have had to give her a ton of fluid in there because what else would change the ECG
Well, I
and the
wonder if
calcium
she
so quickly?
had like some sort of like metastatic cancer and
Yeah.
that's breaking down bone
Yeah.
and that's why we're getting such a high calcium. But I mean, I'm so glad we're going over these EKGs because they're hard. And
Yeah.
I think it was 55% of the audience said this was STEMI. So we're really like split 50-50.
Almost an even split, yeah.
It's hard.
Yeah. And could I see myself would I call it code? I think I would likely call it code STEMI. If she didn't look right to me,
Yeah.
I can see myself doing that. How fast can I get a calcium level back?
Yeah.
I don't know. That's why we're doing. That's why
Yeah.
we're going through this though, because these are the actual. That's one thing about EKGs. You can't make up a case. Like you can't draw it and say, look, that was a real patient, right?
Yeah.
So I mean,
And they're
this is-
humbling.
they're very humbling.
And
yeah.
that EKG, you don't look at that EKG and say, oh, this is hypercalcemia.
No.
Like,
No.
it's a matter of like looking through it carefully, thinking what
Yeah.
looks weird here, what
Yes.
causes that.
Yes.
We look at the patient, what could she have? It's just the bigger picture.
Yeah.
Absolutely.
So I don't want anyone to think that we're all looking at this EKG and going hypercalcemia.
Absolutely.
No, I looked at it and said
Yeah.
pericarditis.
Yeah, that was my initial thought,
Yeah.
and then
Yeah.
and I would have probably called the code STEMI without enough information. I would have. Okay, so there we have it, and the audience was kind of evenly split, and that's just one more time for you to look at, and then I believe we have one more. Ready?
Let's do it.
Case 5.
Number 5 was a 70-year-old man who had called 911 because of acute chest pain. Paramedics got this EKG and called us and told us that they're bringing him to the emergency department. So if you're receiving that box call from the paramedics, what would you tell them when you saw this EKG?
Well, so I think, I tell them, hurry up.
Step on the
I
gas.
tell them to get here quickly because I do not like the looks, especially of the elevation in V1.
Yeah, let me see. Let me just see if I can make that big for you.
But Jan, one thing that stands out is it's slow too.
It's very Brady. I
don't
mean, the
like
rate
that.
is 48 or something like that. But Britt, it could
Yeah,
be.
I
It
mean,
could be
he-
just beta blockers or.
Yeah, he definitely could be on medications. He's 70. He likely is on a calcium channel blocker, beta blocker. I would love to see an old EKG, right? You always want to compare to old, but it's a bit of a wide QRS complex as well.
It is. I'm looking at lead like 2, 3. Not loving those either.
Yeah.
Inferior leads.
Inferior.
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 2, 3, and
There we
AVF.
go. Yeah. Like.
Okay,
yeah,
so
look at that.
there's
Yeah.
2,
Yeesh.
and there's 3, and there's AVF.
Yeah,
so
I
they
don't
all
like
have
those.
Yeah, they're none of them are normal.
So I'm thinking it's slow. I see inferior changes. It's also right bundle.
Yeah, so
right?
that's what I was going to bring up.
Yeah.
The computer tells you right at the top, this is a right bundle. So I think a lot of people would look at this and say, well, it's a right bundle. So
Yeah.
the rules might be different, right?
But
No?
V1 sticks out because with the right bundle, you have to take this into context of the right bundle branch being there, but you should see a little bit, especially in the anterior leads, a little bit of ST depression and that T wave inversion that you do see, but in V1, that's a little more elevated than I
all
feel
right.
comfortable
So this
with.
does not look, okay, Jen, yes.
And don't forget, it is a 70-year-old with acute chest pain. So
Yeah.
it's the right clinical
Yes.
scenario that really raises the suspicion. Like,
Okay,
yeah.
now let me just make a couple of concise statements. That does not look like the typical right bundle branch block that we're used to seeing. And I'm going to show that. I've got a normal right bundle branch block to show you. So that's number 1.
Okay.
And number 2, let me just say this as simply as possible. Right bundle branch block does not take away the signs of STEMI.
No.
It doesn't take, the Q waves are Q waves. That's a Q wave, okay? And the ST segment elevation is also ST segment elevation. So, get out of that bundle branch block mode and look at the ST segments and look for Q waves. And this patient's got them. So this, to me, is an RBBB plus an MI.
And one of the questions coming from the audience is, what is his blood pressure? And that might be relevant, especially if he's got inferior MI. You might
Yes.
expect that it would be low
Yep.
if that's right side involved.
Yep.
And
for sure.
that would make it slow because it can take out the SA node.
Yeah. Well, I mean, and that might be the Brady,
Right.
the cause of the
that
Brady.
might be
right?
the Brady or
Right.
polypharmacy. We don't know
Right.
yet.
So just to be crystal clear, that does not look like a normal V1 in a right bundle. Okay,
Yeah.
it's got a Q wave and it's got ST segment elevation, and so does V2. Well, V2 has the ST segment elevation, doesn't have the Q wave. But if I show you, is this the normal one?
Yes.
This is a normal bundle branch block. So look at V1 here. And that's what you're used to
Yeah.
seeing, right?
You see a little bit of
You see a
depression.
little bit of depression. So the thing is, the computer is programmed for like a millimeter of elevation. It's not necessarily thinking out the nuance of this. Oh, if it's a right bundle, it normally should be a bit depressed. And so even a half a millimeter of elevation, like we have here, is really significant in the presence of a right bundle branch block. So
So I think to answer Amal's question, step on the gas, get moving, and I think we're all in agreement. We're calling it a STEMI
I would.
Yeah.
with what we have so far.
let's see what Amal says.
Well, after what the crew have taught you, hopefully you know that what you ought to tell these paramedics is give the patient some aspirin and drive fast to the nearest cath facility, because this patient is having an anterior STEMI.
Aha, okay.
But again,
Anterior STEMI, yeah.
It's not slam dunk, right? You're thinking maybe inferior because the inferior leads look weird.
Yeah.
I'm thinking, I don't know, anterior, who knows?
Well, I think it was the V1 and the V2 that looked the ugly.
and the
Yeah.
audience is pretty split 50-50
Yeah.
as well.
Yeah, that's the thing. 52%
These are
STEMI,
not-
47%
these are not
non-STEMI.
straightforward.
These are not- that's why we're talking
absolutely.
about
Yeah,
them.
that's what we're talking about them. So this is an acute STEMI with right bundle branch block. And I think if we have, let me just see if we have the...
I do like your point, Britt, about the old EKG. That would have been helpful. 'Cause I'll
would
bet-
I love
oh,
that.
so
Yeah,
helpful.
so
This is the
helpful.
this is the
I mean, it's the
original
first
ECG.
thing I asked for. Whenever I see an EKG that looks weird, my first question, is this a new weird
Right.
or the stable old weird?
Right, no, totally.
Yeah.
Because
let's-
that is helpful.
Let's summarize the main points. So we've seen a couple of MIs here, and we've learned a couple of really key mimics, right? So in the first case, we learned the really critical differential diagnosis in the kind of the wide, regular, ugly-looking EKG. That's a VTAC, STEMI, hyper-K, and drugs, and that was really important. The second case was the
Massive PE.
The massive PE, and so in that one, it's like if they've got a history that sounds a little bit more PE-ish, and you're seeing mostly the right-sided leads showing the ST segment elevations, and you have that axis shift,
And they're paraplegic.
and they're paraplegic.
With no cardiac risk factors, sudden onset,
Fred, so-
right heart
you
strain
got
on
it, right? And the third-
ultrasound.
okay. But seriously, really, really important. The third case was a STEMI. What was the third one? Was a STEMI, right?
Yes.
And okay. And
It
then
was
the
a
fourth
good- it was a-
one.
it was a good
It was a good
inferior
clear STEMI. Oh yeah. And the
RCA
issue there
STEMI.
was like, don't let LVH,
Yes.
fool you. Big voltages, don't
Yep.
let it fool you. The changes in LVH should just be where they should be. They shouldn't be in other places along the EKG. And then the fourth case was the hypercalcemia, which we kind of really went through in detail. And then the last case is, don't forget that right bundle branch blocks show the same STEMI signs with ST segment elevation and Q waves, just like anyone else. And that was the teaching point there. So, wow, thank you so much, Amal. Those are great
Yay!
cases.
Amal.
Thank you.
All right, so next up, we are going to move to our board review, which is an oral board case where I'm in the hot seat and I'm a little nervous. Let's check it out.
As you should be.
Too oaky. Awful.
Lame.
What are you looking at? Too piney. Don't like it.
Boring.
I can't see. Too woody. Bollocks.
Boring.
I said I can't see. Not woody enough. Absolutely awful.
Boo! Ow!
Ow.
All right, guys. It's been a couple years since I took the oral board, so I'm actually feeling really nervous right now, like I'm taking a test. I want to show you how, before we even start, how I set up my kind of piece of paper and organize my thoughts. So ABEM will give you kind of this outline where you have a stick figure and your kind of four square box over here. Before the case even starts, I write down a few things. One, I'm going to initially write down, I'm going to get vital signs, IV, O2, and monitor. I'm going to remind myself if this person is brought in by paramedics, it's hard to remember this, so ask EMS to stay. Then I'm gonna go over here. This is where I'm going to put my HPI. I always put allergies and meds to remind myself to ask for that. This box is going to be my pertinent physical exam findings. This is going to be orders and results. And then this is going to be my actions that I need to remember to do as the case progresses. Now, I also often forget some of the important physical exam things because it's just a little hard when you're not seeing the patient in front of you. So I go to the stick figure and I put an N in the head to remind me to do a good neuro exam. I make this mark here to remind me to do a skin exam. An arrow reminding me to roll the patient and always look at the back. And then I circle here to remind me to do a GU exam. Those are the ones that I kind of forget sometimes. So I just, especially when I'm nervous before a test and during a test, I write that to make sure I don't forget. Okay, so Jan is going to proctor this exam. Jan, be nice. I'm ready.
I will definitely be nice, Dr. Guest, but I want to welcome you to ABEM General.
Thank you.
And we are here to do an oral exam. And so I'm going to give you, as per usual, just some basic demographics. Are you ready?
I'm ready.
Okay. So Dr. Guest, your patient is a 26-year-old female who's being brought in by paramedics after a motor vehicle accident. I'll give you some initial vital signs.
Okay.
All right. You've got a blood pressure of 110/70. You got a heart rate of 100. You've got a respiratory rate of 25, an initial sat on room air O2 sat of 93%. And your patient is rolling in right now.
Okay. Do I have a temperature?
There's no temperature at this time.
Okay, I'd like to get a temperature. I'd also like to get a point of care glucose as soon as she comes in. This person's coming by EMS, I'm assuming?
That is correct.
Great. I'd like to ask them to stay. While we're getting her into the room, I'd like to ask my nurses to get 2 large bore IVs, place this person on some oxygen, nasal cannula. We can start at 2 liters. And then I'd like to have this patient on a cardiac monitor.
Okay, Dr. Guest, all will be done.
Okay, wonderful. Quickly, I want to just assess the airway, breathing, circulation, do my primary survey. So what does the airway look like?
So the airway appears to be patent. She can answer your questions.
Okay. Breathing?
She is breathing, but with some difficulty. She seems to be having some pain. And on your auscultation, you hear some decreased breath sounds on the right side.
Okay, decreased on the right. All right, then circulation.
You feel pulses in all 4 extremities.
Okay.
She seems well perfused. Good tap refill.
Then I just, disability, quick GCS.
GCS of 15.
Okay, and then I'd like to expose her, get all of her clothes off. Is there any obvious bleeding, bony deformity or anything that I see?
You do notice on the left lower leg that she has, looks like an open tibial fracture.
Okay.
She also has some bruising and ecchymosis on her right leg, right thigh, right hip area.
Okay.
That's about it.
All right. Just gonna go over here. So the right lung was a problem, the left leg was a problem. Okay, EMS, can you give me a little bit more history on what happened?
Sure. It looks like this was a pretty bad accident.
Okay.
It was a head-on collision with another vehicle. They had to spend some time on scene extricating this patient, so some passenger space intrusion. And basically she's complaining en route of some chest pain, abdomen pain, the legs hurting, lower back's hurting. But she's been able to answer their questions, been cooperative throughout the ride.
Okay, thank you so much. I'm going to turn to the patient. Patient, can you tell me where you're having the most pain?
Yeah, my leg really hurts. My belly's kind of hurting. My back is killing me.
Okay.
I could really use some pain medicine, and it's just, I'm having a hard time breathing.
Okay, I'd love to give you some pain medicine. Do you have any allergies?
I don't have any allergies.
Okay, so let's go ahead, nursing, if we could give 75 micrograms of fentanyl, please. And patient, do you have any medical problems that I should be aware of?
My thyroid's an issue. I take, oh God, what's it called? Levothyroxine.
Levothyroxine, okay. Any surgery, history, or any other medical problems that I should know about?
No.
Okay. And then for the open tib fib, are your vaccines up to date, including tetanus?
I don't know.
Okay. All right. So I'm going to go ahead. I'd like to perform a physical exam while we get her pain medicine on board. Also, nursing, once you give that pain medicine, can I get repeat vital signs, please?
Yes.
Okay. I'm going to go starting from the top. What do I see on my HENT exam?
You see a small abrasion on her forehead, but otherwise negative.
Okay. Going down in the neck, do we have her in C-collar?
She is in a C-collar.
Do I palpate any pain in her midline C-spine?
No.
Great. Anything on the chest?
Yes, she is tender to palpation on that right side where you heard the decreased breath sounds with a little crepitus there. And that, yes, that's hurting her.
Okay. And I'd like to order a chest x-ray, and I'd like to do an E-fast just to take a look. Can I perform that E-fast and get those results?
Yeah, tell me what kind of views do you want?
Okay, so for the chest, I would use the linear probe, and I'd look bilaterally in kind of the mid-clavicular. Do I see lung sliding?
You do not see lung sliding on the right.
Okay. All right. Can I ask a tech to get me set up for a chest tube, please? And
Yes.
I'd also like to order 20 of lidocaine as well.
20 what?
Milligrams of lidocaine.
Okay.
And I would also like to complete the fast by looking in the right upper quadrant, subxiphoid, left upper quadrant, and suprapubic views, please.
Okay, you do see some possible free fluid in the right upper quadrant. So you see a stripe there.
All right. I'd also like to go ahead at this point and call my surgery team since I do have a positive fast.
Okay, the clerk will work on that.
Okay. Just completing the rest of my exam. Heart and lungs.
So again, you still hear decreased breath sounds on the right. Your heart sounds normal, tachycardic.
Okay. Abdomen.
Lower tenderness, tenderness to the lower quadrants.
Pelvis.
Stable.
Extremity exam.
You have the open tibial fracture on the left lower leg, and you have some bruising on the right leg, otherwise normal.
Okay. GU exam.
Normal.
Skin.
The bruising, the open fracture, otherwise normal.
Back.
How do you want to do that?
I'm going to hold the patient in C-spine precautions and log roll them.
Okay. And then what are you going to do?
I'm going to palpate down the C-spine, thoracic, lumbar. I want to check for rectal tone, and I want to look for any signs of trauma.
Okay, that's normal.
Okay. At this point, this patient has a pneumothorax on the right, so I'd like to go ahead and place a chest tube.
All right, where would you like to put that?
So I would go mid-axillary, fourth intercostal space.
Okay.
Doing injecting lidocaine and then making the incision to insert my tube.
Okay. She's having a lot of pain with your chest tube insertion.
Okay, I'd like to go ahead and give her another dose of that 75 of fentanyl, and if she's still having pain, draw up ketamine so we could use that if she's still not tolerating.
Very good.
Okay. Can I get a set of repeat vital signs now that we've placed the chest tube and given her the pain medicine, please?
Sure. Your blood pressure is 100/75. Your heart rate is 120. Your respiratory rate is 20. Your sat is 97% with your nasal cannula oxygen.
Okay. She's not getting any better. I think at this point, she is getting progressively more tachycardic. I'd like to get at least one bag of O-negative blood drawn up for her, and I'd like to draw some labs as well.
So a unit of O-negative packed red blood cells?
Yes, please.
Okay. How fast would you like those administered, Dr. Guest?
Wide open.
Okay. We'll work on
and
that.
then after we give that first unit of blood, if we could please get another set of repeat vital signs.
Okay.
And I'd like to make sure that we update her tetanus shot and administer some cefazolin for the open fracture.
Okay.
Okay, at this point, if her vital signs haven't changed drastically, I'd like to get her over to the CT scanner.
All right. What kind of CTs would you like to order?
This sounds like a pretty bad trauma, so I would like to go ahead and get a CT of the brain and C-spine non-con, and then I do a CTA of the chest, abdomen, and pelvis.
Okay, these will be performed.
Wonderful. I'd like to also go ahead and page ortho, let them know that we have this open fracture. And have I heard back from trauma?
Yeah, they were in the OR, but the clerk did get a hold of them, and they're on their way down.
Excellent. All right. How are we doing on those CTs?
They're cooking.
All right.
Would you like
at
any
this
blood
point,
work, Dr. Guest? Any labs?
Yes, labs. Yes, I wanted the labs. I would like a CBC, CMP, type and screen, a pregnancy test, and a lipase, and I think, and a lactate, please.
Okay.
And a VBG.
Excellent.
Thank you so much.
It will be done.
Excellent.
All right. There is a phone call for you from radiology.
Oh gosh. Hello.
Hello.
This is Dr. Guest.
Is this the ER physician?
It is.
Hello.
Hi.
I have a critical result for you.
Oh boy.
Well, the good news is your CT head and neck look fine.
Okay.
Chest, you have obviously placed a chest tube. You have 2 rib fractures on that right side, rib 7 and 8. But the bad news is I'm seeing a grade 3 splenic laceration with hemoperitoneum on your abdomen CT. Were you expecting this result?
I mean, she was tender in her abdomen. It seemed more of her lower abdomen, but we did see the positive fast exam, and right upper quadrant is where blood in a supine patient tends to collect first, so not unexpected.
Okay.
Thank you so much.
You're welcome.
All right, so I'd like to go to the patient and update the patient on our findings, as well as get a set of repeat vital signs since she's been back from the scanner, and kind of reassess how she's doing.
Doctor, can you get me out of this C-collar? This neck thing is bothering me.
Actually, yes, your CT of your cervical spine is negative, so we can go ahead and get that off. Otherwise, how is your pain? How are you feeling?
Oh, my belly hurts.
Okay. We're going to give you another dose of fentanyl. You do have you had the collapsed lung on the right. We've placed a chest tube. You have some rib fractures there. Unfortunately, you also in this car accident injured your spleen. So we're going to have to talk to the general surgeons. While I'm waiting for them, I'd also like to put a splint on the left leg to stabilize that fracture, which also will help with your pain.
Okay.
Do I have a surgeon?
Your surgeon has arrived. What can I do for you?
Hi, thank you so much for coming. I have this patient. She sounds like she was in a pretty bad car accident. An initial assessment, she had decreased breath sounds on the right, no lung sliding on ultrasound. We placed a chest tube. It's been difficult to control her pain. She's gotten multiple rounds of fentanyl. Her blood pressure was soft and she was persistently tachycardic, so she did get a unit of O negative blood. I have paged ortho. She has an open tibia fracture on the left that we've splinted. And I am really hopeful that you could admit her and manage this splenic laceration and the rest of her traumatic injuries.
Yeah, sounds like a tough case. Yeah, we'll be happy to admit her.
All right, amazing. Thank you.
All right, Dr. Guest, any final orders or things you would like to clarify before we close the case?
You know, I think the only thing I probably should add on doing is I'd like to give a consult to social work. It sounds like this patient's probably going to go upstairs pretty quickly, but make sure that her family is contacted and those kind of issues are taken care of.
All right, this is the end of the case, Dr. Guest.
Amazing.
All right.
I hate taking tests. That's so nerve-wracking. Hopefully this is helpful in at least seeing one approach to organizing your thoughts. And now let's turn it back to Jan and Stuart, who are going to give me feedback and some constructive criticism, I'm sure.
How about some praise?
Yeah.
I thought that was fantastic. I mean, I know as an examiner, you immediately know that this is a candidate with the program, you know, like that is organized and just the way that you went through it shows that you're a real pro. And so I think that's sort of the bottom line is that that's what an examiner is expecting to see, is to see someone who's like, okay, you know, you forget a thing or two, and the examiners are pretty, you know, good about sort of reminding you, it's like, oh, she really knows what she's doing. She just forgot to ask this. I think that's not how you're going to flunk a test like this. So I think that's the most important message here, is that being organized like that, having that template and that diagram, that's the route to success, I think, on these.
Yeah, I definitely think that you set the tone very well by, you know, oral exams are a game. and you have to know what the script is, like hold the EMS, when I look at the patient, what do I see? Describe for me. One thing I wonder, and Stuart and I have been in the game for a long time, done lots of exams. Stuart, what do you think about, telling the nurse what to do sort of in third person versus like role playing and acting saying, you did. It was a mix here.
I think she did a pretty.
You did talk to the patient at the end, Britt, about explaining the patient's injuries and what's going to happen. And I think that's great. That gets you points in the interpersonal communication category.
Right.
And would you do that all the way through?
Yeah, no, I think that's a huge issue. Is that sometimes that'll make or break the difference between a pass or fail. So. As much as you can, like you as an examiner, Jen, you do that very well, right?
Yeah.
You're like, and we enjoy that. We enjoy. That's the only chance we have to have any fun in an oral exam day is to, get into, character,
I like that part.
right? But you should do the same thing as an examinee, right? And so you do a lot of that. I think you could do even more and talk in a soft, gentle voice to the patient. I know that you're in a lot of pain. That kind of talk, I think, gets you somewhere. I think that's so the more that you can do that, the better.
Yeah. Don't miss the easy points. Those are easy points.
Yeah. You talk to the nurse like, I'm very concerned about her pain. Those types of tones I think are helpful because we would think, hey, that's probably how she acts in real life, and I love that. I like the way that there's a couple of small things at the beginning, and this is like procedural stuff, right? Like. The C-spine issue and C-spine protection, I was always taught, get that out of the way right at the beginning so that they don't go back and say, oh, you're just noticing there's no C-spine collar now? Oh, the patient's been jostling around. So some people in their initial mantra say, I want to make sure that the patient's on a backboard and C-spine precautions. So they put that at all times, and any movement will be done with full precautions, that kind of thing, right? So that's for sure. And then also the blood draws, right? Like when you're initially getting the IV in, it's such an easy time to say, look, I want to draw a whole bunch of tubes and I'm going to tell you, nurse, what they're for. And then you've already got it on the record, so to speak. So those are two little kind of things. There might have been a couple others that I had in my mantra. I can't remember, but those are some important things to say at the beginning.
All right, so I passed.
Oh, no question you passed. I mean, you got all the critical injuries and all the critical actions. I mean, it was brilliantly done, I think, yeah.
Well, I think, it's some of those things that you just know by seeing a physical patient in front of you, you just don't get from the oral board. So you'd see a patient in a C-collar, right? But you have to make sure that you're verbalizing everything, doing the exam, and asking to take everything off and look for the bleeding. Because the bleeding, the broken bones, you're not going to miss that in real life, but very easy to accidentally not ask about it on the oral boards.
For sure.
There was a question in the chat about the utility of lactate in trauma and ordering a lactate in trauma, and I think that in general we know that our trauma colleagues really like it. They've been into base deficit and lactate and trending it for a while. I think that in terms of the initial value of a lactate, it really is a non-specific marker of poor perfusion and sort of badness. But I think that's reasonable to order it. It wouldn't be a critical action on an oral exam. I don't think if you didn't order it you would fail, but I think it's a good thing to include.
And I think, it's kind of like the point of care hemoglobin that everybody is so excited to hear.
Right.
Hers could have been totally normal. I still would have transfused blood.
Right.
She's getting more tachycardic. She's getting a little bit more hypotensive. And has an open fracture. I see a positive FAST. She's bleeding. The hemoglobin just hasn't caught up yet.
Yeah.
Absolutely. Yeah.
Absolutely.
A lesson we've all learned many, many times.
Many
over.
times. Don't trust that initial
For sure.
first normal hemoglobin.
Britt, a lot of people, just one last thing, like a general comment. A lot of people, when they're doing their oral exams, oh, this is so artificial, and this is, I can't see the patient. And when I hear that, I think, what, compared to what? A multiple choice exam? I think that oral exams are the best way for us to make cases up for each other and to study and to actually, I think they're really valuable.
All right, well, we are running out of time. We've reached the end of our show. Couple things that I want to remind everyone. Our next EM Grand Rounds is December 6th. Remember, we go every other month, EM and urgent care. So our next EM is December 6th, and our next urgent care is going to be, oh, I'm so sorry, I flipped those. Wow, I don't know what month it is. Maybe my GCS is decreased. I'm so sorry. So our next EM Grand Rounds is January 10th, so next year, and then urgent care is December 6th. I want to thank you guys both so much for being in studio, and Amal, thank you so much for sharing those EKGs, and Scott with the really crazy bleeding fistula, because I think that's probably all scared the poop out of us many
And
times.
Tom and Graham
And our production
Katie.
team. They're amazing. So thank you guys so much, and we'll see you next month.